Okay. Hello, everyone. I'd like to welcome everyone to the first ever LivsMed APAC region ArtiSential webinar. My name is Jean Lee, and I work in the overseas sales department at LivsMed in Korea. Today's webinar topic will be why ArtiSential in colorectal. We will have 5 speakers from the APAC region and Dr. Yoon Lee from St. Mary's Hospital and Dr. Uk Bae from Kyeimyung University, Dongsan Medical Center as moderators. They also will be presenting their cases as well. Thank you very much to all the attendees of this webinar, and I hope you learn more about the benefits of using the ArtiSential in your surgeries. I'd like to start off with a brief company introduction. Of course, LivsMed is committed to bringing innovative technology to minimally invasive surgery. Our flagship product, ArtiSential, puts the articulation of robotic surgery in the hands of the user without any added equipment or capital. We have revolutionized traditional laparoscopy by introducing the articulation and dexterity of a robotic system in a laparoscopic instrument without the loss of tactile feedback or the costs related to robots in the market. I would like to introduce Dr. Yoon Lee as he will be one of the moderators today. So Dr. Yoon Lee is a renowned professor in gastroenterology surgery at Seoul St. Mary's Hospital and is very experienced in minimally invasive and robotic surgery. He's an expert in colon cancer, rectal cancer, laparoscopic surgery, and inflammatory intestinal disease. Dr. Lee is constantly trying to extend the frontiers of modern medicine and improve treatment outcomes. Dr. Lee will now give his opening remarks for the webinar.
Good evening, everyone, and welcome to the first Asian Pacific LivsMed ArtiSential webinar. I'm proudly introduce our 7 very experienced and outstanding speakers are ready to deliver you very informative knowledge and information of the using ArtiSential in colorectal surgery. So I'd like to introduce the first speaker. The first speaker is Dr. Kevin Huang. Is a fellow of Royal Australian College of Surgeons, is now working as a consultant general surgeon in Bundaberg Hospital, Queensland. So he will talk about the Austrian experience of ArtiSential and his personal experience and training pathway. So Dr. Kevin, please.
Thank you. Now, how do I start this? Good evening. I'm Dr. Kevin Huang. I'm a general surgeon at Bundaberg Hospital. I've been invited to share my experience with ArtiSential. I truly believe this is the next step in our laparoscopic surgery and is a bridge between laparoscopic and robotic surgery. I have no disclosures to make other than that I'm a fan. I find it very helpful, and I want you all to have what I have. Firstly, Bundaberg. If you look at this Google Map image of Australia, you're not going to find us. You will actually have to zoom in to southeast Queensland and travel about 4 hours north of Brisbane to find us. We are a regional town of about just over 100,000 people, but we're growing rapidly with many retirees moving up from Melbourne and Sydney, seeking the sun and the relaxed lifestyle in their later years. As you can see from this aerial image of the town, we are flat, we have water, and we have predominantly agricultural industries. We grow a lot of sugar cane, and we're famous for sugar, sugary drinks, and rum that is made from waste molasses from the sugar mills. Of about 250 beds. We have 4 operating theatres, 1 endoscopy suite, an ICU with 4 ventilated beds, and we're staffed by 5 general surgeons, 5 orthopedic surgeons, 3 gynecologists, and unfortunately, we don't have any subspecialties like plastic surgery, urology, ENT, vascular, neuro, or cardiac surgery. We, however, have been promised a new state-of-the-art 400-bed hospital to open in 2027. But as with all large government projects, I do expect delays. Of the 5 general surgeons, we all deal with everything that comes through the door, from farming traumas, road accidents, acute appendicitis, hot gallbladders, perforated viscera, elective hernias, oncologic surgeries, etc. We do it all. And because of the abundance of sugar and alcohol and a population with high percentage of low socioeconomic profile people, we call this normal for Bundaberg. So you can imagine, I'm a keen laparoscopic surgeon, so I don't have to make massive incisions and deal with its associated wound complications. These 2 graphs are government data from 10 years ago, so it's a bit old, showing approximately 65% of our adult population being overweight or obese, and over 20% can be considered alcoholics. And looking at what we're dealing with now, 10 years down the track, I think we will be higher than that. So for those of you who are not yet familiar with ArtiSential, it's a range of articulated laparoscopic instruments, including different types of graspers, dissectors, needle drivers, scissors, hook and spatula diathermies, and soon to be available advanced energy devices pending regulatory approval. And it mimics our movements, as you can see here. You don't need me to tell you that articulated instruments are just better than straight sticks. Even though I consider myself an expert chopstick user, as many of you are too in Asia, and we probably could do parts of an open operation with it, I definitely wouldn't prefer it. After all, using chopsticks will give us 4 degrees of freedoms of movement versus laparoscopic equipment is an expensive robotic platform, like the Da Vinci Xi we can see here. Last I heard, it cost about $5.8 million Australian. And God knows how much more the next generation Da Vinci 5 platform with force feedback will be when it's available. I certainly won't be holding my breath for Queensland Health to purchase a robot for our new hospital. Here's a short video of the ArtiSential at performing a simple peg transfer task compared to conventional laparoscopic instruments. It's easy to see how limited straight stick instruments are, and yet most of us persist with it and manage to do complex surgeries with it. So just imagine what you can achieve with the ArtiSential.
Next.
And here is a video comparing the ArtiSential to a robot at suturing. As you can see, it's virtually impossible to distinguish the two when used in expert hands. Now I'll highlight how I came to incorporate ArtiSential into my clinical practice. As a self-confessed geeky person, I'm naturally drawn towards new technologies. So when the Da Vinci became available and was promoted, I sought it out and did an immersion course on the sidelines of an international conference. However, due to where I work, I've actually not had any real clinical experience using the robot. So when I saw ArtiSential at a display booth during a conference a few years later, I played with it and thought it was interesting enough to leave my contact details. Next came notification and attendance of a locally run workshop. Whilst my experience on the Da Vinci is really intuitive, the ArtiSential isn't actually that far behind. It does, however, require training to gain a different set of muscle memories compared to conventional laparoscopic operating. And this is where the workshop attendances come in. Each workshop is around 3 hours long, with a proctor and several reps who will help you work through drills of varying difficulties. You will learn to use the instrument one hand at a time, getting more and more familiar with the various movements and getting faster and faster with the drills. Next, you incorporate the other hand into the mix and move on to more advanced skills such as suturing and knot tying. There is a comprehensive training pathway with the drills and targeted times for each drill. After my first workshop, I was sent a demo instrument and the trainer box, as you can see here. I would guess it took approximately 10 hours of playing on the trainer that the movement with the ArtiSential became almost second nature, and I didn't really need to think about how to coordinate my hand, wrist, arm, and shoulder movements to achieve a certain goal. And here is roughly how long you should expect to take to achieve each level. And this is a quick guide to ArtiSential training. It details what each drill is targeting, and it has a scorecard with target times and a space to record your own progress. And these are some of the training videos.
This is the first drill. We grab each peg perpendicular and place it in the board above. So this is pegboard 1, moving to pegboard 2. Once you've done that, you then move from pegboard 1 to what we call pegboard 3. Note there'll be 2 places left. And then finally, once you've done that, from pegboard 1 to pegboard 4. So the exercise is to pick each peg up, hold grasping perpendicular, rotate, and then replace it. And you can pick it up from this side or this side, depending upon where you want to extend the beginning or the end of your motion. Work your way through every single peg, and then again the same here, and so forth. The time required is to rotate all the pegs inside this board. Then you'll repeat the exercise for all the pegs located in pegboard 2, pegboard 3, and pegboard 4, and the target time is the same to be with the non-dominant hand to improve on the target time for the level you wish to reach in 1, 2, 3, and 4. Exercise 3, instead of grasping the pegs from the top, we now grasp the pegs from the side, moving them to the corresponding pegboard. Again, we'll be moving from pegboard 1 to pegboard 2, first of all. Sometimes if it's tight, you might choose to do this. Pegboard 1 to pegboard 2. Working your way around, like that. From pegboard 1 to 3, like this. Again, filling the board up, sideways on. Unlike the drill 1, we're grasping sideways on each time. And then finally, 1 to 4. In each instance, the time required is the same, going from 1 to 4. In this exercise, we're starting to learn two-handed skills. In each instance, we'll be taking from pegboard 1 and placing it into 2, 3, or 4. The first variation, we will use our dominant hand, which in my case is my right hand, and that will grasp the peg and pick it up in a perpendicular manner. And then we will go to the target pegboard, which for the first part of the exercise is pegboard 2, and then I will grasp the peg in the parallel. And then I will complete the motion of placing it into pegboard 2 in the parallel. So the transfer is completed over the target pegboard. The reason we do this is that you gain control of the second instrument in precise position. You then repeat the exercise, taking everything from board 1, placing it in board 3. And then you repeat the exercise, taking it from board 1, placing it in board 4. In each instance, the target time is the same. This trains tactile feel for the inside and the outside and gives you the feel for dissecting tissue. So with the non-dominant hand to do the spreading, and the dominant hand to grasp the elastic band, which we will move into from position A to position B. Notice how the suture pad moved. You may find it useful to use some sort of an elastic band just to secure it in place. And you may find it necessary to tap it in place, just to hold it there. And again, once you've got it in place, you can spread dissect and remove the elastic band from the location, placing it into location C, and then you may find it helpful to just tap it into place or hold it in place once you do that. Next, we're going to do suturing. Load the suture onto the suture, and we're going to drive in every direction possible. Place the suture and drive it through towards yourself using the non-dominant hand to press against the suture pad as it comes through. Complete the motion using the non-dominant hand with the grasp rest. Next, we will reverse, do a needle transfer onto the needle. So holding it like this, and we're going to drive the other way. The dominant hand again, and driving back from the direction that we came, using the non-dominant hand to drive through, continue twisting through. As it's passed through, you can complete the motion, and the target time is to do all those back and forth motions, which will teach you how to needle drive in every plane.
This is the company estimate on the benefit of desktop training until usage of ArtiSential became natural. Obviously, the more proficient you are at the trainer box, meaning you've reached the higher levels, the sooner operating using the ArtiSential becomes second nature. Once you're done with the training and you're ready to make the clinical leap, there are potential challenges you might encounter transitioning between the trainer box and the clinical application. First, you have 3D perception whilst practicing on the trainer box, unless you use the videoscopic trainer box, which is terrible and I wouldn't advise it. I would guess most of us are still using 2D laparoscopic stacks, so there will be a period of adjustment to articulation in a flat plane. I was lucky enough that our hospital upgraded 2 of the laparoscopic stacks to 3D just before ArtiSential, and I immediately felt like I've become my own robotic platform with 3D view, instrument articulation, and advanced imaging like indocyanide green capability. The only thing missing for me was the ability to sit comfortably on the console and sip my coffee at will. Secondly, port placement might be slightly different to what you're currently used to. You have to take into account the bulk of the handle and shift it so that you don't clash with your other instrument or patient's hip or thigh. But in general, it means climbing up the dome of the abdomen more towards the midline. This is the video of my first clinical application with the ArtiSential after I felt comfortable with the instrument. It was on a 74-year-old lady with a BMI of 39 who has an ileocecal valve neuroendocrine tumor for a laparoscopic right hemicolectomy. She also had previous abdominal surgeries, so there was some internal adhesions too, adding to the complexity. Normally, someone like this, I would expect a 4 to 5 hour slog, but it only took 3.5 hours. So that was a good start, I thought. So I persisted, and now I've done approximately 30 colectomies, both acute and elective, using the ArtiSential. So I'm not quite what you consider an expert yet. I'm just a beginner. As this is just the first 15 minutes or so of the operating, on my first outing with the instrument, just adhesiolizing before I can even start looking for the ileocolic pedicle, I will direct you to focus your attention on the movement of the grasper and not so much on the dissection. As you can see, the camera work is terrible and there's a lot of extra useless movements. Compared to real experts, where you can watch a short video of the entire operating with no bleeding, no extraneous movements, I'm just not as good a surgeon as I had thought. But despite that, I hope you can appreciate that with the increased ability to maneuver tissues, it's easier to approach what you need to do perpendicularly. You can provide retraction and roll the instrument out of the way so that you don't clash with your other instrument, and also for a better view. I apologize if the video is a bit hard to watch. But there will be more expert videos that we'll have tonight. In summary, there are clear clinical benefits in having articulated laparoscopic instruments, from improved dexterity, increased range of motion, easier access to difficult areas such as down a deep, narrow pelvis, and enhanced precision and control, all of which should hopefully lead to improved clinical outcome with surgery. Only a small minority of us have the grandiose delusion that we've reached peak surgical knowledge and peak technical expertise, and there's nothing more we can do better. For the majority of us, though, what's preventing us from adopting new techniques and learning new skills is the complacency in thinking that what we've been doing is working just fine and is good enough. My own take is that I'm just a country surgeon who's a jack of all trades and a master of none. I'm more than happy to embrace anything that will make operating easier and anything that will give me an edge. There is unfortunately no shortcuts to training and practice. It does take some time and effort to learn a new skill, but it's definitely worth it in my opinion with the ArtiSential. At the end of the day, very few of us working in smaller hospitals are going to have access to robotic platforms. So don't wait for it. Be the robot yourself with the ArtiSential. It's truly an evolution to laparoscopic surgery. It's available now, and it's a bridge to robotic surgery. So embrace it if you consider yourself a minimally invasive surgeon.
Thank you, Dr. Kevin He. Very nice presentation. If anyone who have a question to the speakers, don't hesitate to text on the chatting mode. So I will ask a question instead of you. So what a good the presentation. So let me ask one simple question to you. So what is your recommendation about the overcoming the learning curve to the surgeons who are starting to use ArtiSential in their real practice? So what is your recommendation to overcome the learning curve fast?
Unfortunately, there's no shortcuts, as I mentioned.
Yeah.
You only have to spend time with it. It is very intuitive. You will get it. And once it clicks, it's like riding a bicycle. So for me, I think it took 10 hours. For more skilled person, maybe less. So just be brave and persist. You'll get it, and it will make operating so much better.
Yes, that is exactly the answer that I want from you. That there's no shortcut. Spend time to overcome the learning curve, the training yourself using the dry box first. It takes about 10 hours for you for overcome all the task.
I think so. Yeah.
Yes, actually the 10 hours are not too long but once and I think it's a very good the analogy to it's like riding a bicycle. Once you got it, then you can do everything.
Yes.
Yes. So is there any the question from the other speakers to Dr. Kevin? So you use the both hands in your practice, right?
At the moment, I have only been using the the non-dominant hand as on the grasper.
Mm-hmm.
I find that just by being able to maneuver the tissues around, that's all I need for now.
Mm.
And I'm also cognizant of the cost with the equipment,
Yeah.
trying to save the health service money where it's not necessary. I don't use it. But
Okay.
for colectomies, for major cases, I do.
Okay. Any question from the speakers? No? Okay, thank you, Kevin. What a great presentation.
Thank
I'd
you,
like
Kevin.
to move to the next speaker. Next speaker is Professor Yoshiro Itatani. He is now assistant professor at Department of Surgery, Kyoto University Hospital, Kyoto, Japan. And he will talk about reproduce robotic colorectal surgery using ArtiSential Forceps. Professor Yoshiro, please.
Yes, just a moment, please. Okay. Okay, so can you see my slide?
Yes.
Okay, sure. Let's get started. Oh, thank you so much for a nice introduction, Professor Lee. And I'll also thank LibsMed for giving me such an honor to have a presentation today. So today's talk is to reproduce robotic colorectal surgery using articulated forceps. Okay, so this is today's agenda. First, I will introduce the current status of laparoscopic colorectal surgery in Japan. Then followed by the videos of laparoscopic intersphincteric resection and transanal minimally invasive surgery. So let me begin with the current status of laparoscopic colorectal surgery in Japan. It was 15 years ago that the Da Vinci was first approved as a surgical robot in Japan. And then it took about 10 years before robot-assisted rectal surgery became covered by public health insurance in Japan. Afterward, robot-assisted rectal surgery is spread rapidly in Japan. And 4 years later, robot-assisted colon cancer surgery became covered by public health insurance too. It was 2022. And now, all colorectal cancer surgery is covered by public health insurance when using the surgical robots. And now, so in Japan, we're currently available several robotic devices such as Da Vinci Xi, Da Vinci X, Hinotori. This is from made in Japan, and Da Vinci SP or Hugo RAS system. So sorry. On the this slide showed the approach for colorectal surgery in Japan. Current status of how we approach colorectal surgery. This is from Japanese national database, which is essentially the same as real-world data in Japan. After health insurance approval, rectal surgery, robotic rectal surgery became very increasingly the cases very increased, and so however, currently is still about half of the rectal surgery and colon surgery was performed by laparoscopy. So how about the current status in the world? Historically, roller trial conducted in Western countries have failed to show the benefit of robot-assisted rectal surgery. A similar open conversion rate and longer operative time. However, 5 years later, a real trial conducted in China successfully showed better short-term outcomes, better CRM, better conversion rate, and better estimated blood loss, post-operative complications, and similar operative time. So how about other studies? This study was a propensity score matching using the Japanese National Clinical Database. This is also very similar to the real world data in Japan. And it shows robotic surgery shows better open conversion rate, but longer operative time. Color trial, this is from Korea. It shows in the NAC-RT group, robotic surgery showed better CRM, but longer operative time. This is also from Korea, propensity score matching for NAC-RT patient. It shows better disease-free survival and local recurrence, but longer operative time. So as you can see, these studies, robotic rectal surgery showed better oncological outcomes, but longer operative time. So this slide shows, This slide shows the economic impact of robot-assisted surgery. This is published from one of the biggest hospital, Osaka Red Cross hospitals. So this graph shows the gross profit of the robotic surgery, and this graph shows the gross profit difference between robotic surgery versus laparoscopy. And as you can see here, high anterior resection, low anterior resection, or colon cancer surgery. So all of these surgeries, so when you done with the surgical robot, it shows more cost and much profit when you're done with the robotic surgeries. And so this graph, so in this paper, it says these data are excluded labor cost and maintenance fees. So this is a summary of the comparison between laparoscopy and robotic surgery. So if you can, so when done with the robotic surgery, it shows better short-term outcomes and better long-term outcomes. But these differences are very slight. And so robotic surgery shows longer operative time and much cost. So if you can reproduce robotic movement in a conventional laparoscopy, so it will show better post-operative outcomes, better oncological outcomes, and better medical economics, and better operative time. And so I think the answer is in the ArtiSential articulated forceps. So next I will show you the videos. laparoscopic colorectal surgery with articulated forceps. So before starting videos, I will introduce the concept of dual task interference. This is published at 10 years ago, and so neuroscientifically, so simultaneous two tasks leads to performance deficit. This is because limited cognitive capacity in the lateral prefrontal cortex. When you use ArtiSential, so you can see wrist movement is very intuitive. However, because this is through the trocar, arm movement is opposite direction. So ArtiSential is naturally dual task interference. So which hands should you use when you first introduce ArtiSential? Because so when you use ArtiSential in one hand, it is already dual task interference, and if you use both hands, it may very complex. It requires very complex tasks. So when you use left hand, so your left hand mainly makes surgical field, and if you use right hand, so right hand has to accomplish your mission. So I prefer using left hand, ArtiSential in my left hand. So this is one hand, or I should say left hand technique. Sorry. ArtiSential one-hand technique is very easy for beginner. Shorter training. I think I also took 10 hours to train one hand. And so it is also important to make widespread users. Okay, so let me show you the video of rectal surgery. The left videos is laparoscopy with ArtiSential, and this is robotic surgery. So we start dissection from the right side of the rectum and see the hypogastric nerve. So this is the scene of lymph node dissection around the IMA. Once you find the lumbar vesicular nerve, you preserve these nerves and dissect fat tissues, including lymph nodes. And after dissecting the lymph node at the root of IMA, then we move to the ligation of SRA just after left colic artery goes. After SRA transaction, if you find the branches going to the sigmoid colon, you also dissect these branches as well. And then this is IMV. Transected to complete the so-called high ligation. So before moving to the TMA to the rectal side, so we generally opened intersigmoid recess from the medial to the lateral side. And then going down to the rectal side to proceed TME. So this is the dorsal side of the rectum. And once you find right and left hypogastric nerve, then dissect between these nerves to proceed the dorsal side. This is the right side of the rectum. Just trace white nerve and yellow white tissue line. And this is the left side. So this is the anterior side. To proceed between vagina and mesorectum. So again, this is the dorsal side. Transect small vessels coming from the dorsal side. So this is almost the final view and finished the dissection from the abdominal side. So as you can see, so we can make exactly the same surgical field by using ArtiSential on our left hand. So this is the clinical experience of the rectal gist 3 centimeter above anal verge. And so this patient has very big tumors at the rectum. So we performed neoadjuvant chemotherapy with imatinib for 4 months, and then followed by the transanal resection by using ArtiSential. So this is the tumor, and so we make the dissection line at that dentate line just below the tumor. And proceed dissection into the internal sphincter. So by using ArtiSential, you can make the appropriate traction like this. So once you find the fat tissue of the mesorectum, so then proceed to the internal side. This is the anterior side, and this space is so-called Denonville's fascia. And then dissect the tumors. So I also use only left hand ArtiSential, even though the suturing. And this is the final view of the surgery. So take-home message: one-hand technique better widespread because of dual task interference, and ArtiSential laparoscopic rectal surgery with one-hand technique, good TME performance. ArtiSential tummies with one-hand technique, better field of view. And so I would try soon using ArtiSential laparoscopic colon cancer surgeries. Thank you so much.
Thanks, Professor Yoshihiro. The great surgical video. I enjoyed a lot. So, is there anyone who have a question to Yoshihiro from the speakers? Actually, you are using a one-hand technique.
Yes.
Yes. Is there any specific reason why don't you use a two-hand technique in ArtiSential?
So exactly. So this is a nice question. Thank you. And so generally, I prefer using advanced energy device such as harmonic or whatever in my right hand. In that case, most of the case we prefer using ArtiSential with our left hand. And another reason is cost.
Yes, cost. Yes. But compared to robotic surgery, it's much less
Exactly.
expensive. Yes.
You're right. Exactly.
So usually many surgeons ask me when they start the ArtiSential, so you recommend the starting from one hand using a
One hand.
non-dominant hand.
One hand, non-dominant hand.
Yes. So you are
And-
plan to use a two hand in the future?
Yes, exactly. I would like to try. But
Okay.
it is very important to first you have to get used to using ArtiSential.
So there's a question from the audience that when using ArtiSential on the anal side, do you feel that the surgery became stuck or that movements are obstruct?
Just a moment.
You can check it on the Q&A.
Okay.
Mhm.
When using ArtiSential on the anal side, do you feel that the surgery became stuck or that movement or stuck? So actually, as you see, the surgical field is very narrow. In that case, ArtiSential, I think ArtiSential is very effective to make enough good surgical field.
Okay,
That's-
let's move to the next topic. Thanks, Yoshiro, Professor. Thank you.
Thank you so much.
Next, I will talk about next speaker is me, and I'd like to talk about ArtiSential in colorectal field. 화면 잘 보이나요? Can you check my slide?
네, 잘 보입니다.
Yeah, we can see it.
Okay. Today my topic is ArtiSential in colorectal field. You know, there have been many limitations in the early time of laparoscopic surgery, but thanks to the technological development, now we can use 3D, 4K, and many advanced surgery. But one thing left, poor ergonomics, is still being considered as an inherited limitation of laparoscopic surgery. But many effort had been made to improve poor ergonomics, but you know, it was unfortunately impractical and is not comparable to end-wrist system of robotic Da Vinci robotic system. But I think the ArtiSential is very comparable to the Da Vinci system. So I will skip this the training video. Already you've seen a lot of time before for the previous speakers. So, but one different thing, actually the movement is very similar between the end-wrist system of Da Vinci and ArtiSential, but there's one different thing. That means that in robotic surgery, the arm is attached to the system and only the wrist part is a moving point. But in ArtiSential, because fundamentally it is the laparoscopic instrument, there are two moving points. One is a tip, and the other point is trocar side. This is a kind of the level point. So we can make a movement like that. I can use my hand, and also I can use my shoulder or elbow to make a movement. Understanding this movement is very important to stabilize our shoulder or our elbow during the surgery to reduce the fatigue of surgeon. So actually, I started ArtiSential in the right hemicolectomy first. At that time, I used ArtiSential at my non-dominant hand using harmony in my dominant hand. And then I tried to apply ArtiSential in lower anterior section. At that time, I used both hand ArtiSential, one dominant hand, non-dominant hand ArtiSential clasper, and dominant hand, I use ArtiSential monopolar. And my junior step applied ArtiSential for a single incision laparoscopic appendectomy, and he used ArtiSential as a grasper and also used a conventional laparoscopic monopolar. So actually, it had been 2 or 3 years had passed since of my using of ArtiSential. So I'd like to introduce several potential advantages of ArtiSential in colorectal surgery. The first is a less camera working. Usually we use a 30-degree camera, and then we ask a camera operator to adjust the angle to make a good surgical view. But if surgeon can use ArtiSential, the surgeon can make a good surgical view without asking camera operator to adjust the angle like this. So I'd like to see here, but I don't ask my camera operator to make to adjust the angle to get this field. I just adjust my angle of my left hand to make this surgical view. And one of the advantages that some patient had very tortuous aorta. At that time, once I ligate the IMA, it is very hard to approach the left side of mesocolon. So in that situation, if surgeon can use ArtiSential like this, it is much more easy or less complicated to make a continuous traction and counter traction, and easy to make a good surgical field around here. And also there is an advantage of ArtiSential during the TME. Actually, the starting point TME. Actually, some patients have very prominent sacral promontory. At that time, if surgeon can use a conventional rigid straight instrument, sometimes it is very hard to approach here. But if surgeon can use an articulated instrument, surgeon can make more effective traction or sometimes counter traction when starting the total mesorectal excision for rectal cancer. So this is ArtiSential. The patient had very prominent promontory. At that time, if surgeon can use the rigid straight one, it is very hard to make a counter traction. I have to push up. But if surgeon can use ArtiSential like this, surgeon can make very effective counter traction. The traction is made by assistant. I can make very effective counter traction, and I can see very clearly the areolar tissue or holy plane for TME. Also, the ArtiSential, this is a video of ArtiSential central vascular ligation for right colon cancer surgery. As you can see, if surgeon are familiar with the movements of the ArtiSential, it is not too difficult to make effective traction or sometimes counter traction. This is the iliacoelic artery ligated at its origin site. And you can see in this video, usually I don't ask my camera operator to adjust the angle to get a good surgical view. This is a iliacoelic vein ligate at its origin site and continue to dissect ventral parts of the superior mesenteric artery and vein. And because of this angle can be made by ArtiSential, I can dissect the ventral aspects of superior mesenteric artery and vein, less complicated. And this is a midcoelic artery. Continue to dissect around the midcoelic artery. And like the vein. And continue to dissect it. This is a right branch, and this is left branch. And identify the right branch of midcoelic artery. And ligate it. As you can see, the camera, the angle is almost very stable because there is a less need to adjust the angle to get a good surgical view. And dissect around the gastrocolic trunk of Helen. And I'd like to ligate only colic branch like this. So this is final view using central vascular ligation using ArtiSential. So this is my initial experience of right colon cancer. I compared the articulating ArtiSential group and conventional group. This is very early, very small size, retrospective comparative study. Interestingly, the number of harvest lymph node was significantly higher in ArtiSential group. And what was the interesting was that although I didn't prove the significant reduction of operation time in ArtiSential group, but there I could find a tendency of the shortening, reducing the operation time in ArtiSential group compared to conventional laparoscopic group. What about the comparing ArtiSential with the robotic system? Because it has very similar movement, endurist and ArtiSential. So there are so many studies comparing ArtiSential and robotic surgery in the colorectal field. So this is my video of ArtiSential and Da Vinci, the low anterior section. Usually I use both hands. This is robotic, and this is the ArtiSential. My left hand, I use articulated grasper, and I prefer to use the monopolar. So as you can see, the movement is very similar. This is IMA was ligated, and as you can see here, very effective traction, counter traction could be made with my articulated grasper. Very similar movement compared to the robotic surgery. And this is a TME. This is a robotic TME, and this is a ArtiSential TME. As you can see here, although the patient had prominent sacrum, the surgeon can make effective counter traction or sometimes traction by ArtiSential. This is a posterior side dissection, very similar movement compared to robotic surgery. And this is a right side dissection here. Because of the very beautiful movement of articulated the monopolar, I can make a very sharp dissection along the even in the right and left, or even a deep narrow pelvis in the posterior side too. This is the posterior side, the anterior side again. You can see the movement, and the was very similar to that of the robotic endory system. This is posterior side again. And then divide it, and then make an anastomosis. So recently I report my all experience comparing low anterior resection by using ArtiSential group and robotic group in rectal cancer. The both group was about 70 using a propensity score matching. After matching, I compared 37 cases in both group. The operation time was the significantly shorter in compared to robotic group. Other things were similar. What about lateral pelvic lymph node dissection? One of the most complicated procedure in colorectal field that in Korean practice guideline recommend neoadjuvant chemoradiation followed by TME with the selective lateral pelvic lymph node dissection for high risk group. So after introduction of laparoscopic and robotic surgery in the lateral pelvic lymph node dissection, there had been many studies comparing both procedures. Almost every the study reported that very similar outcome between perioperative outcome, pathology outcome, functional and oncology outcome. Recently, several studies reported better the functional outcomes of robotic surgery over the conventional laparoscopic surgery. But every study is comparing robotic with conventional laparoscopic instrument. Actually, this is my report which compared the robotic and laparoscopic lateral pelvic lymph node dissection. Unfortunately, in this study, I used conventional the laparoscopic instrument. So until now, I didn't compare the robotic and ArtiSential lateral pelvic lymph node dissection yet. My data, the operation time was shorter in laparoscopic group, but the number of harvest lymph node was significantly higher in robotic group. So based on my data, I conclude that the robotic lateral pelvic lymph node was more the complete compared to laparoscopic group. But I said before that this laparoscopic lateral pelvic lymph node dissection, I use conventional one. Why they're using conventional laparoscopic instrument difficult in the lateral pelvic lymph node dissection? As you can see, the node is here, the bath is here. If if surgeons are using registrate instrument, it is very hard to dissect the deep down the lymphatics, which is located lower than the internal iliac artery or internal or external iliac artery vein. But when surgeon can use a robotic system, because the robot has an endory system like this, it is much more convenient to approach the deep, the narrow, the lateral pelvic lymphatic area. But it is impossible to use the robotic system in every single case. Sometimes the surgeon have to use ArtiSential. Once the surgeon are familiar with using ArtiSential, it is less complicated than do a lateral pelvic lymph node dissection compared to using rigid conventional laparoscopic instrument. So this is a comparative video. This is the robotic lateral pelvic lymph node dissection, and this is ArtiSential lateral pelvic lymph node dissection. So because as I shown before, comparing a TME between robotic and laparoscopic ArtiSential surgery, because of this articulated movement of ArtiSential, compared to the conventional laparoscopic instrument, it is much more easy to access this area, obtulate area. This is obturator nerve. And surgeon can expect very similar the movement like Android system of Da Vinci robotic system. And this is obturator nerve. And one of the advantages of ArtiSential during lateral pelvic lymph node dissection is that the surgeon can use more advanced system. Also, surgeon can use more advanced surgical system for fine dissection. Because until now, the bestseller robotic system is still very bulky it is not good for dissection. And this is the internal iliac node group is dissected. So this is a final view. This is a robotic lateral pelvic lymph node dissection. This is a ArtiSential, the lateral pelvic lymph node dissection. This is almost my conclusion. When you compare the ArtiSential with conventional laparoscopic instrument, which is more intuitive and practical, the ArtiSential win. What about cost? Slightly expensive compared to conventional laparoscopic instrument. What about making a good traction and counter traction? ArtiSential win. Which has good ergonomics? ArtiSential win. What about learning curve? I think learning curve very similar to the ArtiSential and conventional laparoscopic surgery for the very young surgeon who are starting both conventional one and ArtiSential. What about compare the robotic and conventional laparoscopic surgery, which is more intuitive? Robotic is much more intuitive. Cost is less in laparoscopic, but traction, ergonomics, learning curve, everything except the cost, the robotic wins. But what about comparing ArtiSential and robotic, which is intuitive practical? Draw. Cost, ArtiSential win compared to robotic surgery, which is good at traction, counter traction. Draw. Which allows the surgeon good ergonomics. Draw. Learning curve, I think there's no the strict the data comparing the learning curve between robotic and ArtiSential, but personally I think the learning curve of robotic is slightly faster than compared to ArtiSential. I think the colorectal surgeons are the soldiers standing at the front line to fight against colorectal disease, including cancer. So I think the ArtiSential could be one of the good weapons to win against this war. Thank you. So is there anyone who want to ask my talk or the comment from the speakers? There is a question from Carlo from Philippines. Hi, Carlo. So he asked me that how did you overcome the difficulty? And do you think ArtiSential can address the issue of longevity of surgeon ergonomics compared to advantage offered by robot? I want to still operate until I am 80 years old. Yes, actually, the similar question I asked to Kevin He about how to overcome the difficulty, how to overcome the learning curve, but there is no shortcut. There is no loyal road. I think we spend more time to train ourselves. The first one is train ourselves in the dry box to overcome the the task and then apply ArtiSential real practice, I think we can overcome the learning curve, less complicated. And compared to robotic system, frankly speaking, just in the point of the ergonomics, I think robot is better, frankly speaking. But we have to consider everything, including the cost and human resources and many resources. So I said before that it is impossible to apply robot system to every single cases. Sometimes we can apply robotic system for various the reasons. So I think, but I strongly can say that ArtiSential could be a good alternative of the robot system, which having allowed us a good ergonomics. Any comments or questions? So I'd like to move the next the topic. The next topic is Professor Huang from Taipei. He's the correctal surgeon, authentic correctal surgeon in Chang Memory Hospital. So Professor Huang, please.
Yes, thank you, Professor Lee. And please wait a little second. Here. Okay. And thank you, Professor Lee. And I'm Shu-Huan Huang from Linkou Chang Memory Hospital. And it's my honor to have the opportunity to share my experience. And today I will discuss my experience and perspective on ArtiSential instruments in minimally invasive colorectal surgery. And I will focus on my initial experience with the first 2 cases of right hemicolectomy. And throughout this presentation, I aim to share not only the technical details but also the lessons I learned and the insight I gained from these 2 cases. And there's no COI need to be disclosed. And here are the 3 main points of today's presentation. And first, and I also briefly present my preparation before the hands-on session. And second, and I will share my very first 2 ArtiSential cases in right hemicolectomy. And third, I will make a short discussion, the pros and cons of applying ArtiSential techniques in right hemicolectomy. And first, and also I would like to introduce these 3 main types of movements in ArtiSential instruments. And the first one on the left side here is just similar to those in laparoscopic instruments, and the movement is just in the opposite movement, and like a seesaw. And the second one, the turning of the arm, the turning of the wrist. And the third one here on the right side, the torquing of the wrist is just in the same direction, and this just like in the robotic surgery. Yeah, so when incorporated these 3 main movements, and we can achieve the same level of motion as robotic surgery. And just before the hands-on procedures, and I also practice with the models provided by the LipsMed at the dry lab. And in addition to regular training, and I also focused on the exercise like the one showed in the video on the left to improve the both hands coordination. And after the initial practice, and I attempt the origami crane training, and just to improve both hands coordination. And then only when I felt the fluency of the both hands was sufficient, so I begin applying this instrument to the patient. And then comes the first case, 77-year-old man and diagnosed with A colon adenocarcinoma, T4BN0M1A with liver metastasis. And after systemic therapy, and we performed the right hemicolectomy with combined liver resection. Yeah, also I took the picture as a milestone for me, but I just discovered that the recording machine was not well connected during the surgery. So unfortunately, this case has no video to share. And then comes to the second Then comes to the second cases of ArtiSential, and a 58-year-old woman and presented with a recurrent cecal diverticulitis and an intractable pain despite conservative treatment. And as a result, we decided to perform a right hemicolectomy for her. And this video is played at a double speed. And I tried with both hands with ArtiSential instrument. And first, we expose the ileocecal artery and vein. And due to the benign nature of the condition of her disease, I did not perform a SMV dissection. And with here, due to the articulated arm, and we can easily to loop the vessel from the posterior side and applied the hemolock clip and transect it. And next, we proceeded to dissect it between the gyrotas fascia and mesocolon. And as you can see, and the ArtiSential devices allowed for the movements just similar to robotic system, and especially in this relatively confined space. And the tactile feedbacks and it makes the left hand traction just as precise and as the laparoscopic instrument. And the articulated arms can make a wide range of traction and approach. And here, and we exposed. Oh, sorry. What? Yeah. And here we exposed the duodenum. And there's little advantage of ArtiSential, I think, because there's a locking trigger between the finger. So when there's no need for a big movement, I can choose to lock it and then make it into a laparoscopic instrument with the angle I want. And if I just want to change some angles, and I can make it and unlock and change to the angle I want. And if I need some advanced movement, and I can just unlock it and move it like a robotic system. Then we dissected the lateral side, the white line of thought. And as you can see, I don't need to move my arms and my wrist all the time. And I can just do some semi-lock on the wrist when the angle is good. And I can lock it, use it as a laparoscopic instrument. And unlike, I think it's very good for this instrument because unlike the Da Vinci system, you can only choose to move your arm or to lock it. You can't just do a partial lock of the wrist and keep your arm movement. Like in this movement, I just lock my right wrist and move it like just like a normal, like a conventional laparoscopic instrument because the space here is relatively big. So no, I think there's no need for to move my wrist here. But in here, I can just change my wrist angle and still. And here we separate the momentum from the transverse column. And in this part, and we use a ligature sealing device to accelerate the process. And finally, we utilize this ligature device to transect the marginal artery and finalize the resection. Okay, and as we know, the robotic surgery has been introduced since around 2000 years. Yeah, but however, when it comes to the application in colon surgery, and especially in right hemicolectomy, the benefits are limited. And the randomized controlled trial conducted in 2012 by Dr. Park and compared between robotic surgery and laparoscopic surgery. And the results indicate that the robotic surgery have a higher rate of intracorporeal anastomosis rate, but also have a longer operation time. And the other short-term outcome, including the complication, are the same or similar between two groups. And however, the following long-term outcomes and conducted in 2019 and showed just the same between two groups. And so the robotic just with the same short-term, long-term outcomes, but with a longer operation time and a higher cost in the right hemicolectomy in comparison to traditional laparoscopic. So the ArtiSential, why I think it's so that's why I think the ArtiSential is very suitable in the right hemicolectomy, because the instrument changing speed, tactile feedback, and the working range, especially just like the port setting is just as fast and easy like laparoscopic. And then the wrist movement, we can see like the report by Dr. Yusuke here, are just as the robotic surgery. Yeah, but the main challenge of the ArtiSential is still in its technical threshold. And as mentioned earlier, these three primary movements, laparoscopic, and wrist turning, and wrist torquing, and they have different, this one is in the different direction, and this two is the same direction. So integrating these three movements in both hands is challenging and requires some time for training. But in my personal opinion, it's just a matter of time for every surgeon. So the ArtiSential instrument, it can combine a wide working range, fast instrument changing speed, and tactile feedback, just like the laparoscopic instrument, and with the wrist movements, which can do as same as a robotic instrument. But the benefits of robotic surgery in right hemicolectomy are currently limited. So the ArtiSential instruments can provide advantages in right hemicolectomy once surgeon can overcome the technical threshold. And I must say that although the robotic surgery currently shows limited benefits in colon surgery or right hemicolectomy, and I'm still optimistic about its future. Maybe in the year to come, we may see a kind of robot model capable of performing surgeries faster with more precision than human hands. But under current conditions, and ArtiSential can serve as a great option, bringing the gap between robotic surgery and laparoscopy. And regarding the technical threshold, it's our duty as surgeons to overcome this challenge, to reduce the financial burden on patients and strive for better outcomes. And this is my presentation today. Thank you.
Thank you, Professor Wang. What a great
Thank you.
presentation. I think in the Professor Huang's presentation, I think the partial locking technique is a very important. So can you explain more a little bit in detail to the audience about the partial locking technique using
Yes.
ArtiSential? Yes.
Yeah, thank you. Because we can see, let me choose a instrument. You can see the instrument here, this trigger. And when we use the ArtiSential, our index finger and our thumbs are in work just like the snap, and our middle finger can push the trigger. When we push the trigger here, we can just lock the wrist movement, and then you will lock and move just, and then we only have one movement like the traditional laparoscopic. But when we unlock it, we squeeze it, unlock it, and then the wrist can move again. So we can changing the movement of our wrist to lock and unlock, and we can avoid some necessary movement. But when it comes to robotic instrument, you can only choose move the whole arms of the endo-wrist system or to lock the whole arms of the endo-wrist system. Especially when it comes to tenting. When in our left hand, when need to tent the rectum, and in this time we can just to lock our wrist and use our arms to move to tent and to make a big approach, especially in the rectum surgery. Yeah.
Okay,
So I
okay,
think,
thank you, Professor Huang. Let's move to the next topic.
you.
I'd like to introduce our next speaker, the Mazlan, Luqman Mazlan. He's the consultant colorectal surgeon in Picasso Hospital. He used to be the head of unit of colorectal surgery, department of surgery, the Malaysian University. But he moved to the Picasso Hospital. He's now consultant colorectal surgeon, and he will talk about the ArtiSential, a beginner's journey. The Mazlan, please.
Thank you very much, Professor Yoon Lee and ArtiSential for the very kind invitation. And I will be speaking, I think, basically a lot of what the previous speakers have spoken to, basically their journey. And for me, I don't have anything to disclaim except that I am very much a beginner in using this instrument. So I can give you or attempt to give you a beginner's perspective on how you should take up this very useful instrument, and also what I went through and my mistakes, and hopefully you will be able to not do the same. Now, I dare say that I am a experienced laparoscopic surgeon, and I use a lot of standard laparoscopic instruments. And I am now just beginning my robotic journeys, and I've done a couple of cases. Now, I have been introduced to articulated laparoscopic instruments over the years. In 2017, this was the instrument that came from France. I found it very heavy and cumbersome. And then I also had this other instrument called FlexDex, if I'm not mistaken, which is very bulky and it goes around the wrist and it isn't very easy to take off and take in to put on. And so I found that also very, very inconvenient. And then in 2020, right about after COVID started, and we had a lot of time to explore new things. Our local LivsMed rep approached me and introduced me to this instrument. And then I started looking at some of the videos that were recommended. And I'm sure if you haven't had a look at it, you can have a look at it in YouTube, because there's quite a lot of videos there. And you should be trying to watch all these videos and then try it on the dry model. And this is my first experience on the dry model, and I think I don't need to repeat it, but a lot of the other speakers have spoken about it. So you really gotta try and be good on the dry model. Now, my experience is that it has a steep learning curve. Certainly more than what Professor Yoon Lee mentioned, and I do agree with him. It's certainly more a steep learning curve than it is on the Da Vinci. But if you practice, and they say about 10 hours, then you should be able to reach a certain amount of proficiency to be able to use it confidently. So my mistakes was, number one, I did not completely finish the training videos, which I should have. And unfortunately, I did not have an opportunity to attend a live workshop, as mentioned by the first speaker, which I think is very useful. And when I started with a needle holder first. Now, my suggestion is that try to use either a forceps to retract, or a monopolar, or whether it could be a spade or a hook, because it takes away the other action of trying to hold the different organs. So I find that at least by using by starting off with a needle holder, because my first surgery was actually trying to fix an incisional hernia, which was just a complete disaster because it just didn't go well. And then I also did a mistake of one of the first few cases I did was trying to use two ArtiSential equipments, which then just made me very confused and made it more technically challenging. I've also tried using this device on a TAMIS or transanal minimally invasive surgery case, and I do find it useful, but if you're not used to it, then you will tend to clash the instruments because you don't have, because you're not fully using the instruments as you should, which means using the wristed instruments to retract. Now, this is obviously a slide that is from LivsMed themselves, and they are, and the previous speakers have emphasized that it can be used in a low interior resection, and these are the benefits of the instruments, and it also can be used in TAMIS, and you've seen it very well done by the previous speakers before. Now, that goes to my recommendations. The first is that you should probably finish watching all the training videos, and you have to train at least 10 hours on the dry trainer, and you'll be confident and smooth in your movements. Now, you have to remember that using your wrist does not only involve extending and flexing, which was what happened when I first started. You've got to remember that you are able to supinate and pronate at the same time, so that makes the movement more smooth, and it actually expands the range of movement that's available to you. My advice is to use a non-dominant hand initially for retraction, because I think that would be very useful. And as I mentioned, use one ArtiSential first rather than two, and use a monopolar or spade if you can. And of course, it goes without saying, start on an easier surgery first. Don't do it like me, trying and be a hero and go on an incisional hernia repair with trying to suture. Maybe in high interior resection, if you're a colorectal surgeon and you do that, and start with the easier parts of the technique, like maybe trying to score open the peritoneum, and try to identify the IMA and IMV. And this is one case that I did, and you see that I'm able to use my instrument in a sweeping movement other than cutting. So that's what I found. That was what I found useful. Now, of course, as I said, I'm not an expert, and I truly appreciate the videos that Professor Yoon Lee showed earlier. And on that note, I hope that all of us here will be able to be one of the early adopters of this device, or at least in the early majority. So I think that's all I have to share. Thank you very much. And I'd like to take the opportunity to invite you all to the Asia Pacific Colorectal Conference in Sabah, which we have a range of very distinguished speakers. And of course, Professor Yoon Lee will be trying to give us a live demo on ArtiSential, actually, laparoscopic LAR. So thank you very much. Yeah.
Thank you, Mazlan. Great talk. So I think his recommendation is very, very valuable to many surgeons who want to start using ArtiSential. Choose an easy one and starting from one hand. So I think it is very important recommendation. So every surgeon who want to start to use ArtiSential, please remember the Dr. Mazlan's recommendation. So among your recommendation, what is the most top priority?
I think the most important is to practice on the dry lab.
Yes,
very
yes.
confident with it, rather than trying it, after a few times, and then trying it on your patients, and then you find that you get frustrated, and then you just let it go and start using the standard equipment. So,
Yes.
but don't give up.
Yep. So every answer from the expert today is that practice and try it dry box first. Yes. So it is very important to the take-home message. Okay, thanks, Mazlan.
Thank you.
Yeah,
Thank
see
you.
you soon. Okay, I'd like to move to the next topic. Unfortunately, the Delon Lim is not here. He's still in the OR now. So he sent us a recorded video. So we will play his recorded presentation. I'd like to introduce Dr. Delon Lim. He is working at United Christian Hospital, Hong Kong. So he will talk about use of ArtiSential in challenging colorectal surgery.
Good evening, everyone. My name is Dr. Delon Lim. I'm a consultant specializing in colorectal surgery in the United Christian Hospital. Today, I'm really honored to be invited to deliver a talk about the ArtiSential instrument in challenging colorectal surgeries. And thank you, LibsMed, for the opportunity. As a surgeon, I've always looked for ways to make my surgeries easier and safer. Although we have robotic surgery in our unit, the available sessions are not enough for the large caseload. With ArtiSential, some crucial parts of my surgery could be done, with the vital structures better visualized, and dissection in limited space could be done with more freedom and dexterity, similar to that in colorectal robotic surgery. Unfortunately, I'm not able to deliver this talk today in person due to some other obligations. And if any of you have any questions or comments, please feel free to contact me through the email. Now I've prepared a video presentation for this occasion. Some parts of the video were fast forwarded due to the time limitation. Please enjoy.
Use of ArtiSential in challenging colorectal surgery. Introduction. Traditional laparoscopic surgery has long been the gold standard to colorectal surgery. However, operative parts in confined space, acute angled positions, for example, splenic flexure and areas with crucial structures like lymph node dissection remain challenging even to experienced surgeons. To overcome the challenges in these aspects, many overseas centers try to use the ArtiSential instruments by providing advanced articulation to enhance dexterity and accessibility, and the results were promising. Our center was the first in Hong Kong to introduce and utilize the ArtiSential instruments. The following video shows the application of ArtiSential in different aspects of colorectal surgery. 1. Central venous dissection during right hemicolectomy. 2. Adhesiolysis and TME. 3. Locally advanced descending colon cancer. First case of a 67-year-old female with hepatic flexure carcinoma. Preoperative imaging showed multiple enlarged regional lymph nodes. Laparoscopic CME and CVL were done. Here it showed the dissection around the SMV, with straight instrument obstructing the field. We could see the structures after dissection, the ICA, ICV and SMV. By using ArtiSential Forceps, the outline of the SMV is clearly seen and injury could be minimized during dissection. Here the ileocolic artery is dissected out. Next, the ileocolic artery and veins are clipped and divided. Final pathology showed T3N2, a moderate differentiated adenocarcinoma. Resection margin was clear. Second case is a 70-year-old lady with recurrent rectal cancer. She had history of open TAHBSO for fibroid and malignant rectal polyp local resection by Teo. Adjuvant radiotherapy was given, subsequently found recurrence after 6 months. Staging imaging showed localized disease. Laparoscopic adhesiolysis and TME was performed. Intraoperatively found dense adhesion of small bowel to vaginal vault. By using ArtiSential spatula, the dissection of small bowel from vaginal vault is made much easier and safer. Shows the medial approach of sigmoid colon mobilization. With ArtiSential, the splenic flexure mobilization with dissection of pancreas becomes less challenging. Here it shows the dissection of mesorectum from retroperitoneal structures like the ureter and gonadal vessel. Final pathology showed T3N0 moderate differentiated adenocarcinoma. Resection margin was clear. Third case is a 64-year-old gentleman with locally advanced descending colon cancer. Pre-op imaging showed bulky tumor with suspected invasion to lateral sidewall, gerota fascia and left gonadal vessel. Laparoscopic left hemicolectomy was performed. Here you can see the tumor has invaded to lateral sidewall. Dissection was difficult due to the tangential angle of straight instrument to the sidewall and blocked by the bulky tumor. Using ArtiSential scissors, we could dissect the lateral aspect of the tumor more easily. This was one of the earlier videos in our center in which the spatula was not available yet and our experience with the ArtiSential scissors was limited, hence the hesitation and clumsiness. Now we can use the energy device for dissection after the peritoneum is incised. The lateral mobilization upwards is continued. This shows the mobilization from the Gerota fascia. We can see the dissection plane meeting the gauze placed at the lesser sac after pancreas was lowered from the medial dissection. The splenic flexure was completely mobilized. The involved left gonadal vessel was dissected out and clipped on block with the tumor. Fortunately, the left ureter was not involved and could be safely dissected away from the tumor. The proximal part of the gonadal vessel was clipped and divided. Finally, we could ligate it below the tumor with nylon tape to prepare for distal transection. Confirming perfusion with ICG, the distal transection was done with articulated linear stapler. Distal washout of rectum was done with flatus tube infused with betadine water mixture. Final pathology showed T4BN2, a moderate differentiated adenocarcinoma. Resection margin was clear. In our local experience, we have performed 15 laparoscopic colorectal surgeries using ArtiSential from November 2023 to June 2024. There was no intraoperative complication or device failure. Length of hospital stay was longer as most of the cases utilizing the device were advanced tumors. There was no anastomotic leakage and only 2 cases of chyle leakage, 1 UTI and 1 venous thromboembolism, all of which were treated conservatively. None of the cases was converted to open. The cases ranged from right hemicolectomy to TME and APR. Currently, more cases were performed using ArtiSential instruments, especially after the 5 mm instead of 8 mm instruments were available. More studies will be done in the future as we progress. There are a few challenges I encountered using the ArtiSential instruments. For example, it could clash with the other instruments or the camera. If you are using 2 ArtiSential instruments at the same time, like the forceps and the scissors or spatula, sometimes they clash with each other. Also, as you cannot rotate the tip of the instrument without rotating your wrist, sometimes it is difficult to get an optimal angle for dissection. Lastly, the grabbing power of the ArtiSential forceps appeared to be less comparing to straight instruments. For possible solutions, we should try to avoid placing the working port too close to the camera port and not at the same level. To avoid the 2 ArtiSential instruments clashing with each other, we should try to place the working ports at different vertical levels. For example, one at mid-clavicular line and the other slightly more lateral. For the angle problem, I don't have a perfect solution in mind. We can only hope in the future models we could rotate the tip without twisting our wrist and the bulkiness of the handle could be reduced. Right now we can only try to have more practice using simulation models and to adjust the angle of articulation and position of the tip of instrument before rotating your wrist. For the grabbing power, it may be easier to use conventional straight instruments to retract heavier organs and use ArtiSential during more delicate dissection. I hope in today's webinar, other experts could enlighten us on other possible solutions to these challenges. To conclude, ArtiSential enhances dexterity and accessibility, allowing easier and safer dissection, especially in challenging parts of colorectal surgery, for example dissection in locally advanced tumor and dissection at tricky angles. Thank you.
Okay, thanks, Dr. Lim. Let's move to the last speaker. I'd like to introduce Professor Bae Sung-wook is now associate professor at Department of Surgery School of Medicine, Kyeimyung University, Dongsan, Korea. So he will talk about the ArtiSential for reduced port laparoscopic surgery for colorectal cancer. Professor, please.
Thank you, Chairman. I will share my slide. Good evening. I'm Sung Bae from Kyeimyung University in Korea. I'm so sorry I'm so late because of emergent operation. Today I'm really happy to meet you via webinar. Today my presentation is about the wristed instrumentation for reduced port laparoscopic surgery for obstructed sigmoid colon cancer. As you know, a single port laparoscopic surgery has some advantages, including minimizing parasitic trauma, less post-operative incisional pain, improved cosmetic outcomes, and comparable oncology outcomes for colorectal cancers. However, this surgical approach has some serious problems, including clashing instruments through a single port and the loss of triangulation of instruments and restricted number of working instruments, and most importantly, ergonomic difficulties of surgeons. Especially for colorectal cancer surgery, we have some concerns about traction and counter traction for anatomical dissection. Because usually we use some single port surgeon use only 2 instruments for dissection, and some other single port surgeons use 3 ports. And then they cause also other concerns about oncologic outcomes, because those limited dissection can cause a compromised oncology principle and also limited dissection. Recently, a robotic system has developed to overcome some limitations of laparoscopic surgery. Robotic surgery has these advantages, especially in colorectal cancer surgery. Robotic surgery allows surgeons to have a precise anatomical dissection, nerve preservation. In complex cases, we can do a combined resection, and also we can have a selective minimized procedure for selected cases. And after anastomosis, we can do reinforcing suture, especially for novice or low volume surgeon. Robotic surgery help the surgeons to have more experienced technique. We also we adopted a robotic system to have reduced port robotic approach using a single site platform from the SI and XI system. Robotic single site platform helps us to have single port plus 1 port surgery like this. And recently also we adopted a split platform to have also have 2 port reduced port approach for usually for sigmoid colon cancer. This robotic platform also very helpful. However, as you know, robotic surgery, while various robotic surgery has some systematic advantages, robotic surgery has some disadvantages, including high cost and no force feedback. As you know, ArtiSential has been developed to overcome some disadvantages of robotic surgery, low cost, and we can feel force feedback with articulated function. About 2 years ago, for me, about 6 years ago, I adopted ArtiSential instruments to perform colorectal surgery. In initial phase, I tried to adopt these instruments to perform laparoscopic low-entry resection, multi-port laparoscopic low-entry resection. I think, especially like robotic system in pelvic cavity, using restricted instrumentation, I think I could a little efficiently perform TME. Regarding single port surgery, I also tried to have to perform a single port or laparoscopic appendectomy using ArtiSential instruments. So left hand with ArtiSential instruments, sometimes I could avoid some of collisions between instruments, including camera and energy device or other instruments using wristed movement. Recently, I tried to adapt these instruments to perform two-port or reduced-port laparoscopic surgery for colorectal cancer. This video, I did reinforcing suture using straight and needle holder. Recently, however, recently I tried to routinely use wristed needle holder. A little not so easy. However, I think especially using a 5mm needle holder, a little more advanced compared to before version of ArtiSential. Thanks for your attention.
Okay, thank you for your nice presentation. There's one question from the audience that what is your advice on how to maximize its use during rectal dissection?
Rectal dissection?
Yeah. What
yes.
advice how to maximize its use?
Yes, I think we can modify some movements of technique from robotic surgery. Actually, many surgeons have robotic technique. Also for me, I have some robotic technique, so I can imagine. For example, for a posterior dissection, usually we can use a jaw movement like this during robotic surgery, robotic TME. So actually, I try to also during laparoscopic surgery with ArtiSential, I try to like this movement. And secondly, that means I think a left hand ArtiSential grasping or wristed movement is important. And actually, right hand, some surgeons use endoscopy device. For me, I use usually a wristed monopolar device. Also, wristed movement of a monopolar device. Also, I think also helpful.
Okay, thank you. I'd like to close this webinar, and I'd like to thanks to very much for joining today's webinar for everyone. I hope all of you found the session informative and valuable for your practice of using ArtiSential, and also it was my pleasure to share the insight and engage with such distinguished speakers. Once again, thank you very much for your time and participation. Also, thanks to the LibsMed for the great opportunity to have a great webinar. I'm look forward to connecting with you in the future event, and good night.